We want to start by extending a heartfelt thank you to all the families watching live. Your dedication, strength, and advocacy are what make this community so special. We also want to express our deep gratitude to the incredible doctors who have taken time out of their busy schedules to be here with us today. Your expertise, compassion, and commitment to supporting children with trisomy 13 and 18 make a profound difference in the lives of so many. It is an absolute honor to introduce Dr. John Carey, the founding medical professional of SOFT. Dr. Carey has dedicated his career to the study and care of individuals with trisomy, providing invaluable guidance, research, and support to families and medical professionals alike. His work has shaped the understanding and treatment of these conditions, and we are privileged to have him with us today. Thank you all for being here, and let's get started.
Thank you, Kelly, for that wonderful introduction. And I wanted to wish everyone a happy Trisomy 13 Day. Next Tuesday is Trisomy 18 Day, but because some of us will be out of town, we decided to have a combined Trisomy 13 and Trisomy 18 panel. But wishing you in the future days a happy 18 Trisomy Day as well. So as has been the case of the last few years, we've received an incredibly wonderful, important series of questions. We apologize in advance that we will not be able to answer all 23 questions. Some of them that won't be answered are answered by the other questions, especially those related to heart issues and such. So we apologize for not addressing all of them as specifically as they're stated in the question. Also, the question in Spanish, lo siento, not lo siento, it's for me, but Dr. Hamill does speak and write in Spanish, and he will answer that question by email. Lastly, there was one family, Rebecca, who asked a question related to prenatal care that I'm going to email and, if necessary, call her. So we won't be answering Rebecca's question tonight. But let's jump in. I'm going to start with 5 questions from the beginning that all relate to congenital heart disease. The first comes from Rose. And her daughter has full 18. She's 7 years of age. She had a heart repair by Dr. Hamill for double outright ventral and tetralogy of flow at 6 weeks. Transferred care from California to Omaha. Rose is doing very well. His heart is stable. She isn't on any medication. She's gaining weight. She'll be in Special Olympics next week or this week. They have a new cardiologist, and he says she is stable, cleared for surgeries. Her question is there a need for a consult or more things to be done for the upcoming orthopedic surgeries? One is for the foot in April, and she likely will have spinal care and surgery coming up. So she's particularly concerned, is there anything more that needs to be done? So perhaps Dr. Menon, you and Dr. Hamill might comment on that if you could.
Dr. Hamill, do you want to say something since you took care of her and you have the privilege of meeting this family? So I'll let you start and then I can chime in.
Yeah, thank you. That's very kind, and it's great to hear about Rose. I can't believe she's 7. So I think all children with congenital heart defects need regular follow-up throughout childhood and then a plan for transition to adulthood. And tetralogy of Fallot is a perfect example of something where patients understood that they were fixed, quote unquote, and they don't realize that there are still things that can progress in a disadvantageous way over time and need to be followed and sometimes need to be intervened on. So I guess all I would say is with all of the fear-mongering, et cetera, that people often do when they're faced with a case like this, if they're telling you it's okay, it very likely is okay. But as long as there has been regular cardiological follow-up and the echoes are satisfactory to the cardiologist, I think that I would have no other concerns.
Yes,
Great,
just to
thank you.
add to that, I think an echocardiogram and an electrocardiogram to make sure the cardiac function or the squeeze of the heart is preserved and there is no rhythm issues. And from a cardiology standpoint, that's a good starting point to clear the patients for surgery. The only other issue I would talk about is the spinal repair usually involves quite a bit of fluid exchange, and you really want to make sure that the cardiac function is preserved. The other important issue is the airway. I think it will be a good, time to, talk to your ENT specialist or anesthesiologist to make sure that oftentimes trisomy 13 and 18 babies can have difficult airway, and intubation and post-extubation care can be tricky. So as long as they take a look at this, I think those are the two things I would recommend be done before embarking on the surgery.
Thank you, Dr. Menon.
If I could just add one word to that, I think for any parent with a child with trisomy 18 going or scheduled for surgery, I think that it's important each time to have a discussion with your care team, your anesthesiologist, your surgeon, whoever else is going to participate in that care if you're going to the ICU afterwards, and just put it on the table. So if she bleeds out, are we going to transfuse? Are we going to do ECMO? Are we going to do whatever? And I think that it's only possible to have those conversations in a reasonable way before the time of need is upon you.
So hearing my two brilliant colleagues make their comments, I realized I didn't introduce the panel. So on my screen, I see Dr. James Hamill, cardiac surgeon. To the right of him on my screen is Dr. Shaji Menon, my long-standing colleague at Primary Children's and now in Pennsylvania. Dr. McCaffrey is below them from University of North Carolina. He's a jack of all trades, but also a neonatologist by training and pediatrician. And then my very longtime friend and colleague, Dr. Steve Braddock. Now, I don't see Dr. Green on the screen, at least on my screen. So maybe he wasn't able to join us, but he's an ear, nose, and throat doctor, University of Michigan. I also wanted to add Dr. Hamill and Dr. McCaffrey that Rose did say, thank you for giving us a chance in repairing Rosie's heart. Thank you for being on the panel. I want to thank especially Dr. McCaffrey for being so available to us parents in our online groups. So make that comment too. So the next question also relates to the heart. And it comes from, I'm sorry, I can't read the name because I wrote over it. I apologize. The last name is Anna. My son was refused surgery in the UK because of trisomy 13. He passed away last July. He had pulmonary atresia with a ventricular septal defect, also cutis aplasia and apnea. Do you think they could have done anything? His heart stayed strong and his ductus was a good size, they said. It seems like it was the airway issues that was important. He was tolerating feeds. It was his heart and his apnea that seemed to be the problem. I know pulmonary atresia is a major surgery, but could it have been possibly repaired? So again, it was pulmonary atresia with a VSD. So Dr. Hamill and Menon, comments or?
Pulmonary atresia with ventricular septal defect is in a class of lesions where we would hope to achieve a two-ventricle heart that physiologically has the potential to function the same way that an ordinarily formed heart does. And so, in general, those patients should be somewhat advantaged for survival and a good long-term outcome after surgical repair. there can be a host of issues that make the risk-benefit analysis not as positive for an individual child. So I can't really say what should have been done. But in general, a child with pulmonary atresia and ventricular septal defect, two equally sized or reasonably sized ventricles with good function, I think if everything else falls into place, should really benefit from a corrective operation. And I think that would ordinarily be fairly strongly considered. I think things are difficult in the NHS, though.
The only thing I would like to add, I mean, it's really hard to know what exactly happened in one specific case without reviewing all the medical records. But, pulmonary atresia with ventricular septal defect is the most severest form of tetralogy of Fallot. And one of the key features that will, determine the long-term outcome is how good the pulmonary arteries are. If the pulmonary arteries are really small, in fact, some of these patients may not have normal pulmonary arteries. They may have small vessels coming from the aorta supplying the lungs. In that case, even in the absence of trisomy, the repair can be challenging. So it's really what really ultimately determines the outcome is the size of the pulmonary artery. So sometimes even in babies who don't have trisomy lesion, it can be extremely challenging surgery. It's really hard to know, but it's one of the severe forms of tetralogy of Fallot. As long as the pulmonary arteries are of good size, yes, surgery is an option, but that's the most limiting factor in this condition.
Thank you, Shaji. I get a lot of emails all around the country, Canada, and very often from the UK. There seems, there definitely are areas and places, even in the United States, where there seems to be an outright declining of surgery based on the diagnosis. This might have been decline based on the cardiac issues and not the diagnosis. But it is my impression that the sort of declining of surgery in general, cardiac surgery in the UK, it occurs even more often than we know that it occurs in America. But thank you for that question.
Hey, John,
Yes,
can I ask Sashi and Jim a follow-on
please.
question? So the issue of the airway, you guys. So this comes up all the time with these families. So they hear from people, well, if you are going to have heart surgery, you need to get a trach. Oh no, if you have a trach, you don't qualify for heart surgery. I mean, can we give some people reasonable input on what this decision is all about?
I'd like to weigh in on that if I could. It is a tough question. Yeah, our experience in Omaha when we were doing a lot of this was that we generally did not turn patients down because of their ventilator dependence before surgery. And we did observe that the majority of patients were able to achieve a lower level of respiratory support after surgery than before. And so at that time, my strategy, which was informed by intuition and guesswork, was that we would generally operate first unless there was a known major problem with the airway. We would operate first with the expectation that they were more likely to breathe adequately and have a breathing tube removed and not need tracheostomy after an effective cardiac repair. Now, that was our strategy, but I cannot say for sure that that is proven to be or known to be the best way of going about it. And if Dr. Green were here, I suspect that he would be making the case that maybe we are too reluctant to place the tracheostomy in these children. And one thing is certain is that leaving a child poorly ventilated without a tracheostomy and with chronic carbon dioxide elevation and poor ventilation is very harmful. and that needs to be avoided. So before we conclude that a child is okay without the ventilator or without the tracheostomy, we really need to run blood gases and be sure that they are actually ventilating adequately. So it's a tough question. I don't think we know the answer to that yet. Obviously, tracheostomy it carries huge family costs, needing nursing care at home and constant observation and equipment and such. It's definitely a life-altering intervention. It may be that that's what's best. I don't think we necessarily know the answer for sure. It's probably somewhere in between our overly optimistic approach in Omaha and a perhaps overly cautious approach. But I would let Dr. Green speak before I'd say that, I suppose.
One additional thing I would say is that adequate addressing the airway should not preclude cardiac surgery. I think if a baby needs tracheostomy to maintain good ventilation and oxygenation, the baby should get that. It should not stop the cardiac surgeon from operating or vice versa. The only other thing is if you relieve the airway obstruction, the post-op care, the post-op cardiac care also becomes easier. So I think, just because someone has or needs a tracheostomy does not preclude a cardiac surgery. I just want to emphasize that, these two are independent issues and should be addressed independently.
Absolutely. That's very well put. And I would completely agree. I've never had a difficulty with a patient who had a pre-existing tracheostomy, with or without trisomy, undergoing cardiac surgery. That's a non-issue. It's really just an issue, as you say, separately. Do they require airway support?
And I think both you guys in your answer imply that we're dealing with physicians that are willing to accept that there are airway issues in these babies. I mean, the predicate of the question is interesting because Sam talks about central apnea in his baby. And more than likely, I will bet, and I know Glenn would agree, more than likely, probably this was obstructive apnea, and that they didn't really truly evaluate that. I mean, it's a difficult place, but you guys, thank you very much. You make the great points about individualizing each patient.
Thanks, Marty, for underscoring that issue about what was for so many years thought to be central apnea and the reason why so many children passed away in the first week of life. We know that we were missing obstructive problems wherever they were in the trachea for years. So thanks for re-bringing up that point, which I'm sure Glenn would have been if he could have joined us. The third cardiac question takes a different turn, and so I think it's worthwhile. I think after this one, now we'll see where we are with time. I was going to have two more cardiac questions. So here, her daughter is a rare mosaic trisomy 18, mosaic trisomy 13, but all cells 100% affected at an 80-20 split. Now, that is a very rare condition. I have seen one child that is all the cells have a trisomy. Some of them have 18, some of them have 13. 100% have one or the other, never the same. To my knowledge, there are 5 known individuals. I re-looked it up again today, and I did work with a family from Canada in the early 2000s, and the child at the time was about 3. So Chris asked this question. Chris, if you would like to email me, I can fill you in more on that idea of this rare trisomy. But she was born full term at 7/13. They're in Delaware, preparing for heart surgery. However, due to some degradation in heart function over the past few weeks, the new surgeon who started in January is refusing to do the heart repair, stating imperable heart degradation and possible other organ complications. She has a tracheostomy, a large VSD, pulmonary atresia, but since has had PDA stunts and a catheter reduction plug to better balance blood flow. She also has 5 small renal arteries instead of 2 larger ones. She's responded well to epinephrine. Here are the questions. So just to remind, large VSD, pulmonary atresia, and the PDA of the stent. Are surgeons less likely to take on difficult cases early into a new position, which is why as soon as it became more complicated and risky, they rejected our case? When before were they more willing to hold off on surgery until she was larger, just under a year of age? Let me state that again. When before they were more than willing to hold off on surgery until she was larger, just under a year. Question one. Question two, how quick should our timeline be to find other alternatives? Our cardiologist from home was to find someone else to fix her heart. Any advice?
I would
The first
say it's
question related to
completely
the
understandable.
Pardon, Jim, sorry.
Oh,
Go ahead.
I would say it's completely understandable that a surgeon who is participating in a transition or rebuilding or starting a new program is going to not want to begin with cases of high complexity and high risk, because it does take time for a team to come together and be prepared for the difficult things that can happen along the way. So I think that's expectable and not it's not criminal. It's not a point off on the surgical team for saying this isn't something we can do. As long as they facilitate your transition to care with somebody who does have the full range of options. And if you're in the Northeast, you have lots of options within geographical reach.
Yeah, the only other thing I would say is that the new surgeon at Nemours, who's the chief of surgery, was a dear colleague of ours at University of Utah. He worked with both me and John for many years, and he's a proponent of trisomy 18 repair. So even though he's new to the program, he is, really an expert surgeon. But oftentimes it's not just the surgeon's choice. It's surgeon is of course the main leader, but the team has to be convinced that that's the choice that should be made in a specific case. So if you feel like there are mixed messages or difficult choices, that you can always ask them to refer you to a different center where they may have other options.
I'd agree completely. It's oftentimes billed as the surgeon said no, but the surgeon knows the capabilities of his or her own unit. The ICU doctors have to be on board, the nurses have to be on board. Everybody has to have decided that, yes, this is a good thing to do. It's risky, it's complicated, but we're going to do it. And we're going to do it as well as we do everything else that we do. And if the surgeon recognizes that's not the case, whether it's the surgeon's own preferences or other people's, then the surgery shouldn't be done in that institution. I agree completely. The other question, though, was about timing of repair. And I don't remember, John, if you said how old this child was.
I don't think that we know.
So the only thing on that I'd say is that if the child has a stented ductus arteriosus as the source of their pulmonary blood flow, and if their pulmonary blood flow is adequate, that they have a good oxygen saturation, then they're fairly stable. They can wait. A patient with a good stented ductus or a BT shunt, or even severe pulmonary stenosis, even though they haven't had their ventricular septal defect repaired, they're in a pretty good physiologic spot. They're not going to be a whole lot better just because of surgery, because if their pulmonary blood flow is already balanced and adequate. So once they have that, if saturations are good, then the time pressure is much less.
Thanks, because I was going to ask you to clarify that question too, Jim, about the timeline. That That is important. So we're at the half hour, but I think I'm gonna go to one more cardiac question, and then other questions are related, of course, but we'll move to another area. And so this question is something, Dr. Hamill, you and I have talked about before. Is there any evidence that trisomy 13 can cause inherent cardiomyopathy and weakened heart muscles? Our son had many heart defects, right ventricular aorta, pulmonary atresia, VSD, and was given a PADA stunt at birth, but was denied the larger open heart surgery due to the heart function being too low. His function decreased rapidly during his last few months of life. So I assume he passed away. The cardiologist blamed the trisomy 13 for the poor heart function, but I always questioned it might have been from the medication or other preventable causes. I'm not convinced that the trisomy 13 alone caused a decreased heart function. Shaji or Dr. Hamill, any comments? So this is related to the cardiomyopathy, weakened heart function that occurred.
I mean, we don't have a long-term the data on cardiomyopathy, meaning by the muscle itself being weak in patients with trisomy 13 and 18. The only case report that I'm aware of is in a teenager who developed hypertrophic cardiomyopathy, meaning by abnormal thickening of the heart in trisomy 18. But weakness of the heart and enlargement of the heart, which is dilated cardiomyopathy, has not been primarily reported. But there are so many, other confounding factors like shunt lesion, meaning by having a large shunt, cyanosis, hypoxia, all of this can affect heart function. And that is more commonly the cause for decreased function rather than inherent abnormality of the heart muscle in patients with trisomy 13 and 18 that we know of. Now, with improvement in survival of patients with trisomy 13 and 18 long term, we may learn new things, but at this point, we do not know that they have an inherent weakness of the heart muscle. Most of them developed weakness because of some other reason.
The reason that Dr. Hamill and I discussed this once, maybe it was 2 or 3 years ago, is I was aware of at least 2 case reports of children with trisomy 13 who had left ventricular non-compaction and that form of cardiomyopathy. But that would be so clearly diagnosed. I think the family would have known that they would have known that that was the reason for the weakening heart muscle.
Yeah.
I think that as Dr. Menon was getting at, the limitation here is that we don't have enough long-term follow-up on these children to really know. Anecdotally, we did see children who, even during the period of evaluation and trying to get their transport arranged to Omaha, who in particular developed a hypertrophic appearance of the heart. It is difficult to know whether thickening or weakening of the heart muscle is because of the heart defect itself, or is it because of accidents that happen along the way? Every time you have a cardiac arrest or something, the heart will not come back the way that it was before. There's an injury, there's a price to pay. And so it's hard to know whether it's that or a genetic predisposition as a result of their trisomy. I think we're going to figure that out over time, and especially as more and more children survive out of infancy, I think we'll learn more about that. But the bottom line for surgery is it doesn't really matter why it's there. If the heart has poor function, it has poor function. And risks with surgery and with anything else are greatly increased.
Thank you, Dr. Hamill. I'm going to switch gears here. It doesn't mean we won't call on Dr. Menon and Hamill, but I wanted to address 2 what I would think of almost burning issues in trisomy 18, and then we'll move to 3 questions that relate to the onset of puberty and puberty's role in other medical problems. And hopefully Dr. Braddock can and I can try to answer those questions together. But let me answer this first question by Heidi rather quickly, because there's so little that we know, but we need to know. And that is the issue of elevations of vitamin A in trisomy 18 children. So, and that Heidi goes on to ask vitamin A and seizures in children. So I have learned, and there's nothing published in the literature, that there's at least 5 children I'm aware of who have a vitamin A level that's 1.5 times normal. So if you have an extra 18, there may be some mathematical sense that it's increased by that particular amount, a 50% increase. In Omaha, one of Dr. Hamel's colleagues, Dr. Abdul Rahman, who you may remember, there was chief of genetics around the time he was there. He saw one of the children I know, and from that, he noted that there's a gene on the 18 chromosome that's in the vitamin A pathway. And if that gene somehow was affected in a way that would then cause the 1.5 times level of vitamin A, it might have been the biological explanation. We don't know. I had a conversation when we were in Minnesota last year with their team there about this is a study that we should do. We should gather a number of children, measure vitamin A levels. There might be a funding source for this. At the moment, we don't know how it could be related to seizures, but we know that a few of the children who had the elevated vitamin A also did have a seizure disorder, which about 1/3 of kids with trisomy 18 have. So really, we don't know what this means yet. This could mean just a normal variant related to the gene on the 18 chromosome. It could have some biological effects. Dr. Abdul Rahman recommended, because of vitamin A role with the liver, that everyone who was discovered to have an elevated vitamin A have liver function studies. And I'm always willing to take emails about this question. But I think we need to study this issue. We need to find out whether it could be detrimental. Sandra asks another important question which needs definite study in trisomy 18 in particular, and trisomy 13, but at least for recent questions in 18. I have a full trisomy 18 son with Lennox-Gastaut. So that's a complicated triad of different types of seizures, usually related to having ongoing and tractable seizures, has a particular EEG named after those 2 French doctors, Lennox and Gastaut. So it's not a separate condition. It's actually a type of seizure condition which now we know can occur in the seizure disorder of trisomy 18. However, again, we don't know a lot about the seizure disorder in trisomy 18. Again, some colleagues, when Dr. Hamel was at Nebraska, organized a study through Debbie Bruns's TRICE registry, and we determined in more than 100 children with trisomy 18 cross-sectionally that about 1/3 have a seizure disorder, some well-controlled, some not as well-controlled. But what wasn't addressed in the study was the occurrence of very hard-to-control so-called intractable seizures, which the Lennox-Gastaut type fits into. So the real bottom line point is that we know little about intractable seizures in trisomy 18 because it was not gathered in that database. I'm looking for there to be an intractable seizure expert to come to SOFT this year. I've already been pursuing that. If anyone has anyone as a potential candidate, we would like to sort of create a trisomy 18 seizure expert like we have here with trisomy experts on our panel tonight. I'd like to mold that person if we could. So the question that Sandra is then asking is about anticonvulsant therapy, and I would make sure that her son is seeing a type of child neurologist that specializes in epileptology, that is, the study of epilepsy. Among child neurologists, there are now experts that work on seizures, and that would be good for her son to be seeing. I didn't know if Dr. Braddock or Dr. McCaffrey had any other comments to make about seizures in trisomy 18.
John, I think you have a question coming up related to autonomic function. Is that true?
It's not coming up at the moment.
Okay. So
Quickly.
let me say this then. So
Yes, please.
I've had interaction with a few people over the last year, and I think I don't know how to explain it necessarily, but I think there's a real predilection for autonomic failure in these kids. And I think it probably goes hand in hand with sleep disorders. And the presentation of autonomic failure is generally as you roll into REM sleep. It can manifest as blood pressure issues. It can manifest as apnea. It can manifest as breath holding. It can manifest as seizures. So I think there's a whole world of autonomic dysfunction that we don't really understand with these kids. And it may be related to the hypothalamus, but it may also be related to baroreceptors, like either the vagal receptors or the carotid receptors. And the people who are actually doing work on this are looking at things like vagal nerve stimulators and external carotid baroreceptor stimulation. So I think to think about as we go forward to the next meeting, it would also be really interesting to find someone who's an expert in autonomic failure and autonomic dysfunction.
I would second that very strongly. We observed in many children that they just did not seem to have the same autonomic rescue programming in their brain. And that they would have a vagal episode, like a breath hold episode or little reflux episode, and where another child might have their heart rate go down, and they would struggle, but then their autonomic system would kind of come in to the rescue and pep them back up. But the trisomy child did not, and their heart just slowed and stopped. And this was really in the absence of other obvious organic disease. So I think that's definitely an area of important research. It has effects on heart rhythm, and with heart surgery, I think that there has to be a very careful watch for rhythm disorder that may be related to autonomics. But the other thing, going back to what John was talking about, is that we may not understand the difficult to control seizure, et cetera, but generally speaking, we know enough to know that every child with trisomy 18 and I believe 13 as well needs to be evaluated for seizure, because there is definitely subclinical seizure in infants, especially after stresses like heart surgery or cardiac arrest, and that needs to be looked for actively. And a lot of what I think Dr. Green has made the argument that a lot of what we think of as central apnea may in fact, well, Dr. Carey as well, may in fact be a subclinical seizure.
Thank you. I think just this, I think, is a definite area we have to pursue. I think the autonomic pathway is a good way to look at it, since we know there are temperature control problems, not just in children with trisomy 13 who have holoprosencephaly, which might be related to like the hypothalamus, like you said. So it's definitely another area we need to recruit world-class, maybe autonomic nervous system people conversing with intractable seizure people. So I'm glad you brought that up, Marty, about the autonomic. So it tied in with the questions about the seizures, because there's another question about seizures which hopefully we at least touched on. But I think we're in search of a child neurologist, epileptologist, like a Dr. Hamill. So just keep that in mind. But So I'm going to change now. We have 15 minutes left. And there are three related questions about menstruation and related issues. And so, Dr. Braddock, if I could have your antenna up also with Dr. McCaffrey, but of course, everyone pipe in if they can. But let me address these. I'm going to read kind of all three questions because they're kind of related. Some of them have other sets. So Detha asks, what is the menstrual cycle like for a trisomy 13 child? My granddaughter is 9, has started to develop, so we know it's coming. She has seizures that have been uncontrolled at times. Right now, they're under control. We've been told that hormone suppressants can make seizure activity worse. So, Depo-Provera or something of that sort. We have a meeting with one of the endocrinologists this summer. We don't want to mess with her seizure control and are considering letting nature take its course. So that's related to what might be the risk of putting someone on some kind of progesterone, estrogen, Depo-Provera agent related to puberty, both for birth control and for control of menses, but how that might control seizures. Other question is from Stephanie. There's actually three. My daughter Addison has partial trisomy 13 and is 12 years old. We've been dealing with her menstrual cycle coming and going up quite a bit and have her on birth control to stop them, but no luck. Second question is she's constantly getting UTIs and is a carrier of E. coli. Any medical advice we can get related to these questions? So she's asking about the menstrual cycle being hard to control. They were on birth control pills. The third question, which is related and is by Brandy. And Brandy, if you're online, thank you for that very nice narrative and story that you told us. Her questions are, what is your recommendation on interventions here? Trisomy 18 female who is entering puberty, birth control, hormone suppressants, something else. What are the pros and cons? So in some way that's related. They're all somewhat tied together about puberty and trisomy 13, puberty and trisomy 18, possible role in affecting seizures. Any thoughts, Steve, Marty?
Yeah, well, first of all, puberty in folks who don't have trisomy can also have an effect on seizures. People who are, for whatever reason, may be predisposed, and we see in a number of adolescent girls start having seizures that have normal karyotypes during puberty, and so we assume there's some hormonal impact on that. So that's just from a baseline. In my experience, the kids with trisomy 18 and the fewer older ones I know with trisomy 13 who have gotten to that age can have puberty. They can go into it sometimes precociously or early, which by today's standard is for a girl is under age 8, although I haven't seen that in any of my trisomy patients. Or may not go all the way through puberty. So you run the whole gamut from no puberty to early puberty to typical. And what I talk to the families about is several things. One, we, at least at my institution, have a good working relationship with one of our adolescent gynecologists. And as folks are getting to puberty or starting to get closer to, we have them sit down and talk with the families about what all the current options are. And full disclosure, I work at a Catholic health institution, so some things talking about contraception and all are really delicate here. But we talk to them about what the family can do to try and prepare their daughter and or have menstrual hygiene so they can control their flow or stop flow altogether. And that's whether it's oral contraceptive, that's whether it's injections, there's implants now, there's various things, but it has to be tailored more to each child because some will have reactions to those. Some will have, there's concern that both with seizures, but there's also concern with just other health issues that come up and behavioral changes that'll come up while somebody's on some of the hormonal therapies, whatever, whichever one they choose. So, we try to be realistic. I talk to families. Unfortunately, in our world, their daughters aren't safe, no matter how much they're under their eyesight most of the time. Once they're away, or if they go to school, it's unfortunate to say it doesn't take long for something to happen. But more from the puberty standpoint, we just get them prepared early, long before it starts, to start talking about what the current options are. And I'm not an obstetrician, so I can't keep up on those options. But parents look at me sort of cross-eyed sometimes, like, this isn't something we even thought about. Why are we having this talk? And, we go back to the idea that when this all started, nobody thought about having a 13-year-old either, perhaps, with trisomy 13 or trisomy 18. So, they have an extra chromosome, the girls have an extra chromosome, but that doesn't mean that they're not going to go through a lot of the same adolescent angst that their typical karyotype siblings may have.
Dr.
Thanks,
Carey,
Stephen.
I had a question about contraceptive pills and hepatoblastoma risk. Is that something that ever comes to mind?
Well, that's a
Segue.
that's
Yes.
a great question. Yeah, and you're talking, Steve, at least on my screen to your right, is one of the best people to talk about it because we talk about hepatoblastoma risk. Go ahead, Steve. I'm sorry.
No, that's fine. It is a great question. And like many things, we worry about hormonal risk with any sorts of cancer predispositions. Right now, because we're recommending, or I'm recommending, and John does too, that folks consider tumor surveillance protocols, that we're already being watched for those. And usually by the time that we would be talking about contraception, they should be out of the age group for when we really expect, I'm saying this with my fingers crossed, should be out of the age group of when we typically would expect to see things like hepatoblastoma. That may be changing a little bit in my mindset as to how long we need to screen, but it always is a concern. I think for most of our kids, though, by the time we've gotten to the age where they're showing pubertal changes, I have less concern for hepatoblastoma. It's not zero, but it's less of a concern at that age. And like all things, and I say this for seizure meds, I say this for, all this stuff, try and make sure you use the bare minimum you need, so we don't need high dose this or that, use the bare minimum at that standpoint. And I would recommend continuing surveillance for tumors, which at these ages would be ultrasound. My preference would probably be for ultrasounds.
So going back to Deatha's question about, and given your nice portrayal, Steve, of the uncertainty about, even though puberty may look like it's beginning, how it's going to progress, maybe it's not going to progress, the idea of letting nature take its course and worrying about the seizure control is probably a good way to go. But we'll see what the pediatric endocrinologist, and maybe oftentimes they know the same adolescent gynecology.
And John, I want to bring up also, and I didn't hear in the question if when she said that it's showing signs of puberty, what those signs were, because a lot of kids will have adrenarche, which is the forming hair, axillary hair or pubic hair, start getting more pubic hair. And that has nothing to do with puberty. That's actually more related and probably autonomic, like Marty had discussed before. But we see this in a whole gamut of children who have underlying neurodevelopmental issues, brain function issues. They seem to make hair, but nothing else. It's not like it's necessarily an onset. And I just say that because we have a lot of docs who refer kids in for precocious puberty or early puberty. And it's really just that one part of the cycle that they're developing hair, and they're not going to start breast development. They're not going to at that age start, menses or anything else.
I hate to take time because we're getting close to the end, but has there been a reported case of a conception or a pregnancy carried to a live birth? I'm not aware of any. Um, do we know that there isn't any genetic or physiologic impediment to fertility?
I don't think we know. To my knowledge, Dr. Hamill, there has been in Down syndrome. There are many reported women with Down syndrome who have conceived children. I've not heard in trisomy 13 or trisomy 18 of such. As Steve was alluding to and mentioned, a lot of times the menstruation will stop even in the early 20s, almost like an early menopause. Again, that sounds like a broken record with not having the knowledge to know. We don't know very much about what we're talking about now in young adults with either of these trisomies. So, yeah, but your point is well taken. I wouldn't want to risk the issue of birth control in a young adult, let's say, given the circumstances without knowing something about fertility, which we don't. But
And again, there's not good data because there's still although growing, a paucity of individuals who are gotten to this age. And the same for males with trisomy 13, because there's more than males with trisomy 18. But from a pubertal standpoint or from a fertility, there haven't been enough cases. I'm not aware of any reports, either a woman with trisomy who has conceived and carried a child to term or to live birth, or a male with trisomy who has fathered the child. John may know more about that, but I'm not aware of on either side.
So we're down to the
Hey,
last
John,
3
quick
minutes. Yes,
question.
please, Marty.
Steve. Steve, currently we're talking about screening for tumors up until about 3 years of age, I think, right?
No.
How long? How long?
So when we first published this a few years ago, my recommendation was that we should screen or offer screening if families choose for liver tumors, hepatoblastomas, and kidney tumors, primarily Wilms tumor, the same way we do for other conditions that those are frequent. So that would have been ultrasounds and blood tests called a serum AFP every 3 months until they were 4 years of age. Ultrasounds of the entire abdomen. And then after 4, we would do just kidney ultrasounds until initially age 8, now age 7.
Okay.
However, this is where the change is coming, and John and I have gone around for the last 2.5 years saying we have to make a definitive statement. More recently, because and a member of SOFT, we know of somebody who had all the normal screening, and then after their screening officially stopped when they were 8, they developed a liver tumor. And that sort of threw everything off. And so now my recommendation that I'm leaning towards, with no good data to back it up, would be and John may be hearing this for the first time tonight because I haven't had a chance to talk to him, would be to continue the screening if the families are willing, at least with the ultrasounds of the complete abdomen, up until age 12.
Okay.
What I'm trying to decide, and I don't know the answer to, neither do my tumor friends, which is more effective for picking up or more sensitive for liver tumors. Is the ultrasound more sensitive or is the serum AFP? And I talked to a colleague at CHOP earlier today, just about this subject, anticipating this, and she's not sure either. So what they're doing there for their non-trisomy kids are just the ultrasounds, continuing them up to a later age. And now I think in the effort to be safe, we should be offering or recommending to our families they at least do the complete abdominal ultrasound until age 12.
That's a very difficult question because heart failure itself can lead to a somewhat elevated AFP and definitely to an enlarged liver, and that can even be inhomogeneous and can look like a tumor. And I've had a couple of babies who were in the behind the eight ball position of we can't operate on the heart because we think you have a liver tumor, but we can't biopsy your liver because you have such bad heart disease. And so it's a really tough question. And like everything, something that we're going to learn over time.
I agree with you completely, Jim. And and the ultrasounds are just screens, and then if you have any sense or concern, then you go to MRIs or CAT scans to try and get a better definition. But it's you have to sort of weigh both of those. And part of the issue, and I'm going to have to run here real quick, but part of the issue is we don't really know what the incidence of tumors are in trisomies, particularly in trisomy 18. We've sort of back guesstimated it to be at least 1% risk. But because so many children pass away early and nobody looks, they say, oh, they had trisomy 18, they died, at 4 months of age. Nobody thinks, well, could they also have had a tumor because there are no autopsies? So we have and this is something John and I published before, there's no way to get around that until we start screening people enough that we'll see if we pick anything up early.
Can I just throw out a plea? You mentioned a word there, autopsies. And I know it's not always easy. Not everyone is born in an academic medical center where they do autopsies frequently and without charge. But if it's possible, I would throw out a vote that any parent whose child with trisomy 18 or 13 does die should ask for an autopsy, and that will increase our knowledge. And I'm positive that there will be findings that will teach us more about the next kid.
And Jim, I could say that and I bet everyone has had the same experience. I've never had a parent say they regretted getting an autopsy.
No, agree completely.
I apologize, folks. I have to run. If there are more, particularly about the tumor stuff, or more questions, feel free to email me or email John. I know that he and I are going to be having a conversation about this next week. So we'll go from there. Colleagues, it's good to see you guys. All my friends from SOF, thanks for joining. But sorry, I got to run.
Thanks, Steve. And we are past the hour, and want to respect that for everyone's time. But attempting to end on a positive note, which we'd always like to do, we were never able to get to Samantha's question, which was very important question, many levels. But the first part of the question was, how do we best advocate to change in doctors when they're refusing surgery for our trisomy child? And she adds, respectfully. So nice way to add that there. I think that question could be the entire hour. What do we mean by a narrative? What is the narrative? What bias exists among the medical community, which I will say is changing, and everybody on this call today, and I have to call out Dr. Hamill, have added to that change. But I think that there are a number of events occurring now that weren't occurring even 10 years ago. One of those is better data. And at the risk of sounding trite, we need to follow the data. And the data is changing attitudes. But the audience here tonight and SOFT and other organizations related to trisomy 13 and 18 have changed the narrative. Probably doctors are listening more because you and other predecessors have been asking for it. It's reasonable that the child is in a position to have surgery, and surgery occurs. And now we know, 6 major studies on cardiac surgery just in America, totaling more than 500 kids in the last few years. So it is changing. Doctors are changing, but it's slow. And I think what's coming ahead is some of you are aware that SOFT really has changed the website, and we are talking about developing a support network around the country, ideally around the world, that has to do with this question of advocacy. In addition, some of you may have heard our keynote speaker last year at the SOFT conference, Dr. Benjamin Wilfont from Seattle Children's, heads something called the Trisomy Collaborative, funded by a philanthropic group whose goal was to build a support system. So there you go, two things, SOFT and the Trisomy working together. So I do think that we're still at a snail's pace. It should be faster. Attitudes need to change. But, but as Bob Dylan said, times are a-changing.
Thank
So
you, John, for that.
Go.
I would, to give a pragmatic response to this question, I would say that the most important thing an individual family can do is to plan with their medical team. And the educational materials that SOFT has put out recently emphasize your delivery plan, your care plan, and talking about those questions before it's an emergency and before things start to go wrong, I think is really important. And developing, I guess I'll just say, I, I think we need to give our doctors a chance to tell the truth. Because if we wait until everything is a disaster, they're maybe going to tell you we can't do anything, but maybe there was something they could do. It's just that opportunity has passed already. Having these conversations in advance is a way of giving your doctor a little time to catch up with what you might want and what's possible. Because they say in marketing, the confused mind says no, and doctors are susceptible to that too. But formulating a plan in advance, I think, is really key to having things go the way that you want them to go.
Thank you, Dr. Hemmel. And the resource guide you referred to are the two publications that have come out from SOFT in the last few months, one on trisomy 18, one on trisomy 13, for expected parents. And that was in particular, there was a birth plan in the book. So those books are available online on trisomy.org, both trisomy 18, expectant parent, and trisomy 13. There are also hard copies available that can actually link to be purchased. So those, just in case you weren't familiar with the book that Dr. Hamill referred to, the books, they're in existence. So again, I thank my colleagues. We're almost 10 minutes past the hour, but I think everything that was said past the hour was worthwhile, so thank you. And again, wish everyone a happy Trisomy 13 Day, and for next Tuesday, a happy Trisomy 18 Day.
Happy March, everybody.
Thank you.